strabismus was thought to be inherited pattern, meaning that it's more likely to occur if both parents having the condition. However, we do see many children who they don't have any family history or something related in the parents. Why we are concerned about strabismus? Why do we care? Is it only because of cosmesis? Is it functional reason? The reason why we are concerned about strabismus because it is related to depth perception. Depth perception is stereopsis. So children who have strabismus, they are most likely will have under normal stereopsis. And this under normal stereopsis might lead to prevent them from going for certain jobs later on in life. For example, being a pilot, being a surgeon, working in microscopes. Sometimes they cannot do this. If strabismus started in adulthood, usually patient will have a very annoying symptom, which is double vision, diplopia. And of course, cosmesis is not something that we underestimate because it can lead to psychological problem in children, especially those who are attending schools. We have to clarify some terms. We use orthotropia when we talk about a patient who does not have any deviation in his eyes. Orthotropia means brain is able to fuse the two separate images into one three-dimensional image. And when we talk about dimensional image, we mean the depth perception. The person appreciates the distance between different images in the space. This is the depth perception. If we look here to this cartoon, it just tells you how if the both eyes misaligned, how things will happen. When the eye is deviated in early childhood, the brain may learn to ignore the image from that eye. If you see here, each eye bring the image and the brain will fuse it and it will be in the occipital cortex. So we'll see it upright. But if one eye is deviated, right or left, the brain will learn to suppress the image which comes from the deviated eye. This suppression will lead to amblyopia or lazy eye. If a child, for example, had cataract in early life, and this is normal eye, see the image will fall where here? Into the macula, into the fovea. Here the image will be blurred, and the image which comes from this eye will be difficult for the brain to fuse it with the image which comes from the normal eye. In order to fuse two images, we have to have three conditions. Can anybody name it? Can anybody name what is the three conditions? Any volunteer? Huh? Don't worry if you make a mistake. If we see two images, in order for our brain to fuse it, to make it one, what are the conditions? Similarity in size, yes, shape, and clarity. Three things. If one of these not there, the brain will learn to suppress that image. Of course, in adulthood, the brain does not have this ability to suppress. That's why we have double vision. It's very understood why we have double vision. Today we'll talk about comitant strabismus. What is comitant strabismus? I would like to make some interaction, if you don't mind. I will ask questions. If you can answer, if you can make mistakes, no problem. We are here all to learn. So anyone can say what is comitant strabismus? Very good. So comitant from the word committed. When somebody is committed to something, he will do it no matter what the circumstances is or are. So comitant strabismus means the angle of deviation is the same, whether the patient look right, left, up or down, does not change. Of course, non-comitant, we will not talk about it today. Most likely it is. What is the most likely non-comitant? Paralytic or restrictive. Very good. So look to this child in primary gaze, looks all right, looks normal, right? No deviation. But look when she looked to the left. Is this comitant or non-comitant? This is non-comitant strabismus. This lady is having third nerve palsy. Look when she looked to the right. Completely normal, right? But look here. And look here. Of course, here there is a ptosis. This is another example of non-comitant strabismus. Same thing here. This child is having no deviation here, nothing here, nothing here, nothing here, here. Maybe here, صح? This is a brown. So brown is a restrictive non-comitant strabismus. We'll not talk about non-comitant strabismus today. What are the causes of strabismus? Most likely, we don't know. Most of the time, we don't know the answer. But sometimes we do know the answer. It is more related with children who's having neurological problems. And it can be explained by the refractive status of the child sometimes. But other times, we don't know the cause. Is it at the level of the brain? Or it is at the level of extraocular muscles? We don't really know. These conditions can give rise to strabismus more than the other children, like Down syndrome, cerebral palsy, hydrocephalus, and of course, brain tumors. Majority of children, they are normal. They don't have any of these. Any condition which can reduce the vision of the eye, it can precipitate strabismus or squint. What are the types of comitant strabismus? We have two common types, isotropia and exotropia. Isotropia is divided into another categories. Infantile isotropia, hence the name, and acquired isotropia. Of course, infantile, when we talk infantile isotropia, we mean strabismus or isotropia which occur before the 6 months of age. It is not a condition where the child is born with. Usually children, they are born normally They are not born with isotropia. It happens after birth. That's why we don't call it congenital. It is not congenital condition. It is infantile condition. But by definition should happen before 6 months of age. Why 6 months of age is a cutoff point or a critical age? Because we want to differentiate it from acquired esotropia, which usually occurs after 6 months. Of course, 6 months is not a very definite period of time, but most likely, infantile esotropia will occur before 6 months of age, and accommodative esotropia or acquired esotropia most likely will happen after 6 months of age. This is infantile esotropia. Reason? Big. When you see big esotropia, large angle esotropia, most likely this is infantile esotropia. This child is having infantile, according probably to his age. Other thing, the amount of the angle here is big, right? The other thing, if you see here, he's fixating with the right eye. Here, he is fixating with the left eye. This is good or bad sign? This is good sign. We call this alternative esotropia. And we call it sometimes a cross-fixator. And the good thing about this, they don't develop amblyopia. They don't develop amblyopia. I think I mentioned this before. When both eyes are misaligned during the childhood, we will not have a good binocular vision, because the brain learns to suppress one of the eyes. This is classical example of infantile esotropia. Notice the large ET here. If the patient is always fixating with the left eye, he will have amblyopia, definitely, in the right eye. So this is one of the important things to treat amblyopia, not only cosmesis. So we are concerned about amblyopia in Comitant Strabismus. This child is having the infantile esotropia. And if he keeps fixating with the right eye, the left eye will develop amblyopia. Same thing here, probably same thing. Okay. I mentioned this already, that infantile esotropia is not believed to be co-natal, but rather develops in the first few weeks or months after birth. That's why we don't use the term congenital. We don't say congenital esotropia. This is infantile esotropia. This is the typical orthoptic sheet. If you see the vision, of course, when you evaluate the vision of a child, we evaluate either by follow and fixate. You give him just an toy or anything to see whether he is following or not, or central steady maintain. This is another system of evaluating the child visual acuity. And we have to notice whether he's having nystagmus or no, because nystagmus is related to infantile esotropia. And we have, of course, to know which eye is fixating with. This is important in planning treatment of amblyopia. We have to commence the treatment of amblyopia as soon as possible. when the child visits you in the clinic, you have to know which eye is fixating. You have to answer this question, because at least we will start the treatment of amblyopia. Time is so precious that we need to start treating the amblyopic eye as soon as we know the fixating eye, especially in infantile isotropia. So here is the fixating eye, is the right eye. This means we will patch the right eye. The deviation here, if you see, it's large. And when we say large, we mean anything more than 30. Anything more than 25 or 30, it's considered to be large. So this is 45 and 50. If you notice here, the abduction is not full. Is this sixth nerve palsy? Shabab. Shabab, I need you to talk. Don't be scared to talk. Do you think this is sixth nerve palsy? What is it? Yes. Usually, we don't see full abduction in infantile isotropia. And this is nothing to be worried about. It's not sixth nerve palsy. It is due to the medial recti are so tense that they are pulling the eyes. The child cannot fully abduct his lateral recti. So it is not uncommon to see it. It's not something strange to see it. So when you see it, you don't really worry that much. It's not sixth nerve palsy. And of course, when you do psychological refraction, we expect the spherical equivalent to be not significant. So what is the significant spherical equivalent refraction? Anyone can tell me? Okay, 2 or more. What is the spherical equivalent here? +1. So everybody knows how to calculate spherical equivalent? It is half of the cylinder plus the sphere. So half of the cylinder is minus half, plus 1.5 will be +1. So the spherical equivalent here is not significant. Of course, you have to look to the fundus. Always look at the fundus. The reason behind this, Shabab. Yeah, retinoblastoma is not common at this age. It is okay to be in the back of your mind, but usually rule out neurological causes of a squint. You remember we mentioned cerebral palsy, we mentioned any space-occupying lesion in the brain. So always you want to see a clear and healthy optic disc. And macula, of course. So we are done here. We examined the child. This is the first time. He is, let us 5 months now of his age. We saw him in the clinic. And you told his mother that he's having infantile ET. So the next question, what are you going to do, doctor, for my child? What would be the answer? نبغى اسمع R1 و R2. في R1 و R2 ولا ما في؟ ها؟ طيب تفضل اللي تكلمت يلا. Very good. So we'll patch the right eye. How long? Guess. No problem. كم؟ 6 months, you mean the duration? No, I'm talking about the time. How long you patch the eye every day? Any suggestion? One hour, 2 hours, 6 hours? 1 to 2 hours. Why not 6? Hmm? 6 hours. Why not 8? What is your reference here? The reference is the age. He is 5 months. If you patch him for 6 hours, definitely he will have occlusive amblyopia. صح? So, good number of hours will be 1 to 2. Usually I start by 1. The other thing, you have many years in front of you, so don't be harsh in the beginning. You have few years to come to treat amblyopia. So 1 hour, 2 hours maximum is good. Okay, you told the mother that you need to patch. Next, when you go to do surgery. First of all, would you go for surgery or no? Botox? Yeah, I don't do Botox at all. So I'm a surgeon. Let's talk about surgery. When you will do it, we'll make it interaction يا شباب, huh? So make mistakes, no problem. Why are you so scared from talking? When he is 7 months يعني? Any other suggestion? Okay. Okay, so you have at least a guideline, huh? Good. Yani your colleague is saying that we have to have 2 stable readings over 6 months. Okay, this is good way of approach. My way, I don't operate them before 1 year of age. I never touch them before 1 year of age. The reason? This is only a single visit. Usually children at this age are not cooperative. You cannot do cover test, prism with cover in children like this. You're only doing Krimsky, صح? ولا Hirschberg, which is a gross way of measuring the angle. So angle measurement is not really accurate here. So see him, for example, after 3 months, measure him again, see him at 1 year, measure him again, and plan for surgery. Those who are saying we need to take him immediately for surgery or within 1 month, they are talking about stereopsis. But many studies have had no really difference between the stereopsis if you go for early surgery versus late surgery. And when I say late, I mean doing the surgery before 2 years of age. Of course, we will not wait until he's 3 years. Clear, Shabab? Any question regarding, I gave you now practical approach to this case. Any question? So just mention here what I just said, the classical case of infantile isotropia, more than 20, 25, 30. You remember this child? You saw him before? I think we saw him here. No. Yes. So the treatment is surgery. The treatment for infantile isotropia is surgery. Whether you go for 2 muscles, 3 muscles, it's up to the surgeon and the amount of the squint. So here he went under bilateral medial recession and right lateral rectus resection. What do you think the message here? Treat amblyopia. Because infantile isotropia, if you don't treat amblyopia, they will end up having one eye. Practically, they will end up having one eye. So remember this. Of course, this is the treatment of the amblyopia. Encourage the children to make near tasks like writing, reading, mobiles, or anything when you patch their eyes. What do you think this picture is saying here? This child is told, the mother told to patch him for 3 hours. And what she was doing, every 3 hours to change the patch with a new one for 3 months. So he developed what? Occlusive amblyopia. Yani the amblyopia here was okay. He's 20/20 now, but here now he got amblyopia here. So sometimes, although we tell patients patch 3 hours, we assume that they understand what do we mean, but actually they can understand it in different meanings. So make sure really that you really explain it to the patient. Although we repeat it every day, we think this is our words are taken as guarantee. When we say 3 hours, they understand, but sometimes you need to really explain it very well. It's not the mother's fault. It is our fault that we didn't explain the information very well. So what is the prognosis? Usually we'll have better ocular alignment, and visual prognosis can be achieved if the squint correction done before 2 years of age. The long-term follow-up studies on isotropia, infantile isotropia, showed that surgery done around 2 years of age, 60% will achieve microtropia or small angle after the surgery. I think practically the number is more. It depends. It's different from surgeon to surgeon, but I think it's up to 80%. Probably sorry for the quality of the picture, but this is the recession. This is when we take the muscles back, when we recess the muscle. You remember what I said about binocular vision? When a child got infantile isotropia, he cannot go back to normal. But how much he can improve? Nobody knows. He definitely will improve. What are the factors contributing to poor ocular alignment and visual prognosis? If the amblyopia was not treated before the surgery, this is number one. If the child is having latent manifest nystagmus, myopia is another factor for poor prognosis. So we need to talk about pseudostrabismus. Since we talk about strabismus, we need to talk about pseudostrabismus. What is pseudostrabismus? In a condition which both eyes seems to have squint, but actually they don't. That's why we call it pseudo. Pseudo means false strabismus. This is a classical presentation of pseudostrabismus. See, the epicanthus fold here is prominent, so it will occlude the sclera, and the parents will think the child is having squint. Of course, when the child comes to you in the clinic, you have to do a full examination, do a cover test. Of course, the golden standard test is the cover test. Prognosis, usually good, but some of them, they do develop isotropia, some of the pseudostrabismus. So don't dismiss them from the clinic altogether, but do see them at least once. Or tell the mother that when she started to notice any worsening, come back. Because about 10 to 20%, they do have strabismus. Reason? There's no reason. It's just like general population. It's like any child who can develop strabismus. I'll talk about accommodation before we talk about accommodative isotropia here. So what is accommodation? What is accommodation يا شباب؟ ها يا شباب، والله انتم اليوم زعلانين علي، ما حد يبغى يتكلم. Good. So when we change focus of both eyes from distance to near, our refractive power of the lens will change. صح؟ ممتاز. So when we look at near, what will happen to the lens? Okay, so this is distance and this is near, right? Distant, near. You agree? Okay. So this is what happened. When you look at distance, this. When you look at near, this will happen. So this is constant thing done automatically. We don't really feel it. We are not aware of this. This is something we cannot control. The near reflex is a reflex which consists of three things. What are these three things? Accommodation, which we just saw now. Convergence. What is convergence? Both eyes get closer to each other. And meiosis. What is meiosis? Pupil constriction. So these three things go always together. We cannot control them. We call this near reflex. When we change from distance to near, these three steps or these three actions happen together. Why we are talking about this? Because this really what explains the accommodative isotropia. So accommodative isotropia is something acquired, something the child is not born with until the age of 2 years, most likely until the age of 2 years. But if you want to be precise, after 6 months until 7 years, from 6 months of age until 7 years. If you remember this picture here, this person has no refractive error. Normal person who is not wearing glasses or anything. Imagine a child who is having hyperopia. Hyperopia, you can see this here, where the image is here, right? The image falls behind the retina. So you think he should put more accommodation or less accommodation? More accommodation, exactly. So instead of doing the normal accommodation the person without any hyperopia will do, the child with hyperopia needs to do extra effort to bring the image from behind the retina on the fovea or on the macula. This child is having accommodative esotropia. Look to his eyes here and look when he is having his glasses on, straight. When you have accommodative isotropia, you have to perform, anyway, we always perform psychological refraction, but in accommodative isotropia, we stress it more because you want to achieve or find all the hyperopia. Usually, we give cycloplegia and dilating drops like tropicamide or medriacil. What is the clinical feature of accommodative esotropia? Usually the refractive error is significant. You remember we said the spherical equivalent less than 2? Here the spherical equivalent more than 2. And anything more than 2 is significant. 2.5, 3, 4. But usually they are around this 2 figures. If you practice strabismus long enough, you would hear this from the mother, that the child fell down, after this he developed esotropia. Or the mother will tell you that the child has fever, then after the fever he started to have esotropia. Actually, these two conditions have nothing to do with accommodative esotropia. It just precipitated the illness. So it has nothing to do with the falling down or has nothing to do with the fever or anything. Just this stress out the child that it will precipitate esotropia, accommodative esotropia. So this is common in the clinic to hear this. And usually start intermittent, not like the infantile esotropia. Infantile esotropia will show up and stay the same. Accommodative esotropia will start intermittent, means sometimes there, sometimes not there. And even both parents will fight each other during the first 2 months. The mother will say there is a squint, the father say no, and they will stay 2 months or 3 months until they see it clearly. This is classical history of accommodative esotropia. Do we do surgery for accommodative esotropia? The answer is no. We don't do surgery for accommodative esotropia. The extraocular muscles have nothing to do with this condition. It's pure accommodative cause. So treat the root cause. The root cause here is accommodation, hyperopia. And if you remember, we said it's a smaller angle compared to infantile esotropia. See here, probably 20, 25, maximum 30 maybe. Look here. He's straight, صح? Is he straight here? Yes, look here. Is he straight? No. Why? Maybe wrong glasses. Very good answer. So what do you want to do? Excellent. Repeat psychological refraction. Let's assume that we did this and he came to us in the clinic exactly the same thing. ما أسمع. Check the compliance. Very good, Mohammed. Compliance is good. Very compliant. So you want to say whether he compliant or no? I can assure you he is compliant. We did that and he is compliant. Excellent. If the child looks straight at distant and only having isotropia at near, of course you have to repeat the psychological refraction, make sure that you are giving him the correct refraction. But if he doesn't improve, think of high ACA ratio. The high ACA ratio, child will have ortho at distance, but near he will accommodate more. So as Muhammad said, put +3 in front of his glasses, check the deviation at near. So this is high ACA ratio. And usually you give him bifocal. It's not that common, but we do see them in the clinic. We said before, this is not, This is the orthoptic sheet here. What does this tell you? Diagnosis here. First of all, we have at distance 10 prism diopter. Is this considered to be good result, moderate, bad? Good. So what is the definition of good? Not more than 10. Good. So if you have 10 or less, this is accommodative isotropia. For example, he was 35 isotropia. We gave him glasses and it became 10. صح? Look to the near here. It's 35 without the glasses, but with the glasses 25. Is this good or bad? This is bad. I mean, this is not improvement here. But when we put +3 at near, he became 10. This means diagnosis is what? High ACA ratio. Excellent. Treatment of high ACA ratio is bifocal. The mother will ask you this question: for how long my child will use the glasses? What would be the answer? غير مهند. نبغى نسمع غير مهند. يا شباب. 1 year, 2 years, 3 years, the rest of his life. What do you think? Any guess? Guess يا شباب, you are free to talk. Think. Just give me an answer. What do you think? Child is 3 years now. For how long? 1 year, 2 years, 3 years, 6 years, his rest of life. %50 of children, they will grow out their hyperopia after 7 years of age. Half of them. Half of them will stay, will need the glasses for the rest of their life. So don't promise the mother anything. Tell her that this figure, at least when they cannot get rid of their glasses, you mentioned this before. think I answered this before. So some of them, they will get rid of the glasses. Some of them, unfortunately, they will not. We have something called partial accommodative isotropia. Hence the name partial. Partial means what? Some of the isotropia has improved or corrected by glasses and some not. So look to the orthoptic sheet here. 3-year-old came 6 months ago. We gave him this refraction and now he came back. See, 30/80 without the glasses. With the glasses, he is 15 now. At near 30, at near without the glasses. Here with the glasses, 18. More than 10, the remaining, صح? Well, improvement, more than 10. صح? He improved more than 10 prism diopters, but the remaining is more than 10. So we call this partial accommodative isotropia. What should we do here? Sorry? ما أسمع. Before surgical, we agreed that we always need to. Yes, exactly. Always repeat cycle. Always. Before you go for surgery. If you repeat it and the same thing, I agree with you. You can think of surgery here. So we covered isotropia. Now we'll talk about exodeviation. Probably we have 10 minutes. We need only 5 minutes to cover it. It's not as common as isotropia, although recently I started to see a flip in the incidence of exotropia and isotropia. I started to see more exotropia in our community rather than isotropia. When I started my practice, isotropia was more. Now I started to see exotropia more. I don't know what is the reason behind this. But exodeviation is a horizontal form of strabismus characterized by visual axes that form a divergent angle. Why it is not bothering us? Because it's not associated with amblyopia. This slide is saying that ESO is more than exodeviation with the ratio of 3:1 in this study, but I think we started to see more. We need probably studies here to know which one is more now. It is considered to be more in our area in the Middle East, and probably the reason is that we have more sunny days than the other geographical area of the world. That's why it could be related to this. It's always start with exophoria. Always start with exophoria. Unless it is sensory, of course. I'm talking about strabismus, which is not sensory here. And usually progress to intermittent exotropia. Intermittent means sometimes are there, sometimes are not. And just this explaining that the bitemporal suppression in exotropia develop in children, and intermittent exotropia may finally progress to constant esotropia if it is not treated at the time. It can come early, but usually it does not come like the esotropia, i.e. it comes after 3 years of age. But you can see it at 1 year, 2 years, but usually 3 years or more. We depend on history in intermittent exotropia. We ask the parents how much do they see this exotropia? 50% of the time, 70%, 100%? And if it comes, how long does it stay? 2 seconds, 1 minute, or 10 minutes? Because this will really help us in deciding whether to take the child for surgery or no. That's why we say excellent control or moderate control or poor control. And this actually describes if it's good, the deviation will become less than 5 times. I usually don't follow this, but I ask the mother or the father certain questions. For example, at school, does the child bothered by his colleagues? They notice this? Teachers notice this? When somebody visited at home, do they notice this or no? This is more practical. And when it comes to the child, how long does it stay? This is very important. Some mother will tell you a few seconds. When we call him by name, he will become straight. This is considered as good control. We don't think of surgery. When the child sits at chair and squint, and this is poor, without covering. So all these things to evaluate the severity of the intermittent exotropia. And the classical picture of intermittent exotropia, the mother will tell you when we go out in the sun, the child will close one eye. This is very classical. Reason, we don't know. We don't know why this happened to children with intermittent exotropia. But sometimes can be the chief complaint that the child closes his eye in sun when we go out. And they don't see any deviation. When you examine him, you see intermittent exotropia. Probably you don't need to know all this classification for the poor, good. If you come to the clinic, you will. Okay, probably you have to remember this. Good control where the patient breaks down only after cover test and resume fixation without a blink. Fair control when the patient breaks down after cover test and blinks to reflex. Poor control where the patient breaks down without any form of effusion disruption. Probably, if you remember this will be enough. We have basic type of exotropia where the distance and near is the same when we say basic exotropia. Look to this orthoptic sheet. By the way, when you see this sign, this means intermittent. When you say XT like this means intermittent. If it is constant, we will not put the brackets. So this is intermittent when you see two brackets like this. So at distance he has 25 intermittent XT. At near he has 5 only. Is this basic exotropia? We agreed that basic when the distance is equal to near. Is this basic? Yes or no? No. So what is this? We call this distance near disparity. Distance is not equal to near. The reason for this, why you think somebody is having exotropia and near, the exotropia, most of it will be gone? Because most likely he is accommodating. صح? So to know this, put +3. So when you suspend his accommodation, his exotropia will become apparent. So the distance will become like the near. So what do we call this? Divergence excess. Very good. But is it true or pseudo? Pseudo. Reason for pseudo because when we put +3, he became almost the same. Pseudo divergence excess. Probably this is the last slide here. I just told you about this. Maybe we can talk about this here. What is this? at distance 5, at near is 20. Is this distance near disparity? Yes. When the distance not like the near, we call it distance near disparity. So this is distance near disparity. Reason for this? Convergent, بالضبط, not converging. We call it convergence insufficiency. Yes, and I had some adult, they have this and they go from doctor to doctor, and they change glasses. I don't know why. They have headache. But if you do a cover test, you will have them having convergence insufficiency. So convergence insufficiency is important, especially in adult patients who going from doctor to change the glasses, and they thinking that the problem in the glasses. You don't need to know this because of the time. We have V pattern exotropia. We have. It's okay. This is the end of the lecture. Do you have any question? Yes? Of course, when you have, I got some children come to the emergency, for example. They have isotropia, let's say isotropia. And when you refract them, they are myope. Sometimes they are myope. Extraocular motility is full. Fundus is good. When all these normal, probably if you don't image, nobody will blame you. Okay? But if you do image, at the same time, nobody will blame you. You get my point? When I started my practice, I used to do imaging for those children. But later on, I learned from these cases. I don't now do image them unless they have some systemic hint that they have headache, they have vomiting, they have problems in walking, all these things. You get my point? But if the normal and you examine the fundus and motility, you are sure about it, no need to image them. Welcome. Any question? يعطيكم العافية.